Thank you. Good evening, everyone, and welcome to Health and Freedom, a community conversation with Black and African American families, hosted by the Masonic Cancer Alliance and Faith Work. I'm Ulysses Wright. I'm a member of the KU Cancer Center Community Advisory Board and a proud graduate of Langston University. I'm so honored to be moderating this evening's program. On behalf of the Masonic Cancer Alliance and Faith Works, we appreciate you taking time out of your day to be here with us. Let me see. Before we get started, we have a few housekeeping items. First, this Zoom session is being recorded. Second, if you would like to ask a question, please type your question in the chat box. We've dedicated times during the program where our presenters will answer questions. All right, let's go ahead and get started with Dr. Crystal Lumpkins. Dr. Lumpkins is an associate professor at the University of Kansas School of Medicine in Family Medicine and Community Health Research Division. She also serves on the KU Medical Center Diversity, Equity, and Inclusion Cabinet and is co-chair for Health, Equity, and Community Engagement Subcommittee. She holds a courtesy faculty appointment within the Department of Population Health at KU Med and the William Allen White School of Journalism and Mass Communication at the KU campus in Lawrence. Dr. Lumpkins' current and primary research interests are in evidence-based public health communication, cancer-related genetic counseling and testing communication targeted to minorities and underserved populations. Her research is community-driven, where she takes a community-based participatory research approach to engage Kansas and Missouri communities in research process in the research process to address cancer, health disparities, and health communication inequities. She is currently chair and lead researcher with Faith Works Consortium that is comprised of area health-based and community-based organizations, patients, medical, and research professionals in the bi-state area. Dr. Lumpkins, we appreciate you taking time to be with us tonight, and welcome.
Thank you so much, Mr. Wright. We actually, and thank you for that introduction, we actually had a last minute change, and Dr. Nikki Nolan will go and present first because of some thick obligations she has. And so, Dr. Nolan.
Great. Well, and we can give a little bit more background on Dr. Nolan's as well. Dr. Nolan is a career, Dr. Nolan is focused on understanding social and behavior determinants, the health and health behaviors among vulnerable populations. The long-term goal of her research is to reduce tobacco-related morbidities and mortalities for low-income and racial ethnic minority populations. Two of her current research projects include a study to monitor changes in health outcomes among African American smokers who switch from cigarettes to electronic cigarettes, and a study to examine disparities in quitting between African Americans and white smokers. So, Dr. Nolan, we appreciate you being here with us as well. But let me give you a little bit more background on Dr. Nolan. Dr. Nolan is a professor in the Department of Population Health at the University of Kansas School of Medicine and co-leader of the Cancer Prevention and Control Program within the University of Kansas Cancer Center. Dr. Nolan?
Thank you, and I'm sorry for that last minute switch. I do have a family obligation, so thanks everyone for bearing with the program switch this evening. And thanks so much for having me. I'm going to go ahead and share my screen. Okay, and you guys should be seeing my PowerPoint slides, is that right?
Please switch display settings.
Okay. Is that better?
Yes, we see it. We see it.
Okay, let me move this whole thing out of the way. Okay, so I'm going to be talking for, the first 15, 20 minutes today about the tobacco dependence treatment program that we have been, we've had in partnership with Swope Health Central for the last 22 years. And then we're fortunate this evening to have Miss LaWanda Swoops on, who is one of our former study participants. And so we're going to spend some time hearing from LaWanda about her experiences quitting smoking through the Kick It at Swope programs. Okay, so smoking can damage every part of the body. I think most everyone on this this forum tonight probably knows that. It's related to cancer and then chronic disease of every organ system. Tobacco remains the leading cause of preventable disease and death in the United States. So more than 480,000 US deaths each year are attributed to cigarette smoking, and all of those deaths could be prevented. We've made tremendous progress at reducing smoking rates since 1965, when the US Surgeon General released their first report on smoking and health in the United States. At that point in time, about 42% of the US population smoked. And in 2020, I'm happy to report we reached an all-time low. So the adult smoking prevalence in the United States in 2020 was 12.5%. But that still means that 34 million adults in the United States smoke. And while we've made tremendous progress, that progress has not been equal. Cigarette smoking is substantially higher among certain subgroups of our population. That includes individuals with less than a high school education, those who live at or below the federal poverty level, those who receive Medicaid, have serious psychological distress, identify as lesbian, gay, bisexual, and are racial and ethnic minorities. And I have, if you see here, the in parentheses, the percentage of smokers within each of these groups. But what we know is that these groups are not mutually exclusive, that they intersect and can lead to rates as high as 40% in segments of the US population. When we think specifically about African-American smokers, we know that African-Americans have a smoking prevalence that's similar to non-Hispanic whites. So in 2019, this data is a little bit older than what I just showed you. The smoking prevalence for African-American adults was 14.6 compared to 15 for white adults. We also know that African-Americans smoke fewer cigarettes per day, and they smoke on fewer days per month. So over 70% of African-Americans smoke 10 or fewer cigarettes per day, which we would characterize as light smokers. And that's compared to 41% of whites. We also know that 25% of African Americans are what we would call non-daily smokers, which means they smoke on 1 to 25 days per month. So they don't smoke, they smoke on some, but not all days. African American smokers have a very high motivation to quit. About 73% of African American smokers on average say they're interested in quitting. But given all of these factors, we also know that they're more likely to die from smoking related causes. So this slide is just showing select death rates for smoking attributable diseases by race. And this
Dr.
is,
Nolan,
yes,
could you go back one slide? Because I just want to clarify something.
yes.
So in your second bullet point, you're saying that 7% of African Americans smokers smoke 10 or few cigarettes per day. Is that correct?
Yes, correct. Thanks for clarifying. Right.
Okay,
Yes. So
all right.
of African Americans who smoke, 70% are light smokers who smoke 10 or fewer cigarettes per day. Does that make sense?
Yes.
Okay, Yes, thank you for that clarification. Yeah. Okay, so this slide is showing select death rates from smoking attributable diseases by race. And what you see is that for all causes and then for these select diseases, that there is a disparity. So African Americans have a higher death rate from these causes than whites. We know that over 85% of lung, head, and neck cancers and 30% of all cancers are attributed to smoking. So this slide is just simply showing that smoking is not just attributed to cancer of the lung, it's attributed to cancer of many body systems. And if you look at cancer death rates by race, we have seen a narrowing through the years, but again, if you're looking here at the yellow bar, the top bar, which is cancer death rates for African Americans, relative to the other primary racial and ethnic groups in the United States, you see that the rates are highest for African Americans than they are for the other racial and ethnic groups. And you often hear that African American smokers are less successful at quitting. That is an apples to oranges comparison. So in the studies that make this comparison, what's often happening and what we know is happening is that African American smokers are less likely to be offered treatment. And when treatment is offered, it's often of poorer or lower quality. So that's really been the goal of the tobacco dependence treatment program at the University of Kansas Medical Center. So our goal is to provide evidence-based tobacco dependence treatment to racial and ethnic minority smokers. And this treatment program represents a 22-year partnership with Swope Health Central. All of our research programs are conducted at our Swope Health Central location, which I think has been key to our success. So we've had a total of 8 large-scale clinical trials that have been funded over the last 22 years. And we've enrolled and treated more than 3,000 African-American smokers in one of those 8 programs. And I'm going to tell you a little bit more about some of those programs today. I can't tell you about all of them. So the goal of our program is to provide evidence-based care. So what is evidence-based care for tobacco dependence? So clinical practice guidelines recommend the combination of smoking cessation counseling and one of the 7 FDA approved first-line therapies. And that would be nicotine gum, patch, lozenge, inhaler, nasal spray, and then 2 non-nicotine medications, bupropion and varenicline. And that the combination of counseling plus one of these 7 therapies doubles the odds of quitting compared to cold turkey. And our studies, we have used virtually all of these evidence-based approaches. So you'll see, each of the approaches that we've used in our studies and the studies that have used them. I'll talk in detail about a couple of these studies. So bupropion is one of the 2 non-nicotine medications that's been approved for treatment of smokers. We've done 2 studies with bupropion and African-American smokers. The first study was called KISS-1 or Kick It at Swope 1. And this study enrolled African-American moderate to heavy daily smokers, so those who smoked 20 or more cigarettes per day. We provided treatment of either bupropion or placebo for 7 weeks. And what we found was that bupropion was more effective than placebo during active treatment, so during that 7-week time period, and then during long-term follow-up. And our long-term follow-up period is always 6 months. It's the standard in the field. So if we found that 36% quit at week 7 with bupropion and 21% remained quit at month 6. In a follow-up study to that, we looked exclusively at African-American light daily smokers. So this was a population prior to this KISS-3 study. This was a population that had been virtually excluded from clinical trials. There was a feeling in the field that light smokers are not that addicted and they can quit on their own without evidence-based care. So we provided, again, the same treatment, bupropion or placebo, for 7 weeks. And again, we found that bupropion was more effective than placebo during the active treatment phase, so during the time that people were actually taking the medications. But at long-term follow-up, we no longer saw a difference. So we found 24% quit at week 7 and 13% remained quit at month 6. Varenicline is one of the other non-nicotine medications that is FDA approved for treatment of smoking. We've done 2 studies here. KISS-4, we enrolled African-American smokers across the full spectrum, so light, moderate, and heavy smokers. We provided varenicline for 12 weeks or placebo. And we found that varenicline was more effective than placebo during active treatment and long-term follow-up. So 18% quit at week 12 and 15% remained quit at month 6. Another study was, we wanted to look at quit rates between African-American and white smokers when provided the exact same treatment. And everyone in this study received varenicline for 12 weeks. There was no placebo. So everyone got active treatment. And we found that African-American and white smokers achieved the same rate of abstinence when stratified by socioeconomic disadvantage. And that's an important point. That's that kind of apples to oranges comparison that I was talking about earlier. You have to look at people. Socioeconomic status is one factor that greatly impacts smoking status and ability to quit. And so when you look at individuals of the same socioeconomic disadvantage, you see similar quit rates. So we achieved a 22% abstinence rate overall in this study. We found a 24%, a 24% quit rate with individuals who had the least amount of socioeconomic disadvantage, and a 13% quit rate with those who had the most disadvantage. And then we also have done some studies with nicotine replacement therapy. So we've used, again, in African-American light smokers, again, 10 or less cigarettes per day. We looked at nicotine gum versus placebo gum and motivational enhancement counseling or health education counseling. Health education counseling is more solution problem focused. Motivational counseling is just what it says. It's designed to enhance motivation. This is a study that was interesting in that we found that nicotine gum was not better than placebo gum, but that advice-oriented health education counseling was better than motivational enhancement counseling. And this finding has been found over again by several other investigators in terms of the style of counseling that works best for our African-American smokers who are interested in quitting. So in this study, we achieved 19% quit rates at week 8 and 14.2% remained quit at month 6. The last study I'll describe, and then I'll wrap it up with some insights and lessons learned. So as I mentioned before, about of African Americans who smoke, about 25% are considered non-daily smokers. So they smoke some, but not all days of the month. There's only been 3 teams across the US who have really looked at this population of smokers. There's this idea that non-daily smokers, again, like light smokers, are not very addicted and can quit on their own. So we did a study where we provided counseling with or without the choice of nicotine gum, patch, or lozenge. And we found that counseling plus one of these 3 products, one of these nicotine replacement products, led to greater reduction in smoking days and cigarette consumption. We found an 11% abstinence rate at week 12 and 7% who remained abstinent at month 6. And we also found a 53% reduction in the potent lung carcinogen NNAL. So NNAL is the primary causative agent in lung cancer. And among this population of non-daily smokers, we achieved a significant reduction in their exposure to NNAL. So pulling it all together, insights and lessons learned. So across our studies, we found that African-American smokers are highly engaged in treatment and they're successful at quitting across therapies. So across studies, over 80% return for their study visits. We consistently find very good compliance to medication, with the exception of gum, and I'll talk about this here in the next bullet. We've achieved 13 to 24% quit rate, percent of individuals who are still quit at month 6, which is very comparable with other studies in other populations. And that the chance of quitting is 50 to 200% higher with medication relative to placebo. In terms of the medications, what we're tending to find is that non-nicotine medications, specifically varenicline and bupropion, may be more effective. This is consistent also with what has been found in other populations of smokers. This is likely due to adherence. So these non-nicotine medications and the nicotine patch are a 1 pill a day thing. So you take the pill in the morning and you forget about it, which is very different than the nicotine replacement therapies, which sometimes require as many as 20 doses of gum or lozenge per day. So they're just really hard. Participants find them hard to use. They don't use enough of them. And they don't experience benefit. So future directions, I just want to talk about some of the studies that we have upcoming. So what about the smoker who isn't ready to quit? We are interested in the potential of e-cigarettes for tobacco harm reduction. And then we also have another study that will be starting that is for the smoker who wants to quit. Does extending treatment beyond the standard 7 to 12 weeks leads to better outcomes? So these are the 2 upcoming studies. So just for the rationale for the e-cigarette study is that there's a continuum of risk when it comes to tobacco products, with combustible tobacco being cigarettes and cigars being the most harmful product. The goal is always to get an individual to quit. That's the first goal. But there are many individuals who aren't interested in quitting. And so then the idea is, for that population, can we do something that is better than the combustible tobacco that may lead to less risk? And e-cigarettes are on the lower end of the risk continuum for those who aren't interested in quitting. There is evidence that e-cigarettes lead to less short-term harm compared to cigarettes. And we did a study here at SWOPE and also with some collaborators in San Diego, where we looked at e-cigarettes on tobacco harm reduction for African American and Latinx smokers. And what we found was that individuals who switched fully or partially experienced significant reductions in the same lung carcinogen that I spoke about earlier, NNAL. So Quit to Live 4 is coming. This study will be for adult cigarette smokers who are interested in trying electronic cigarettes, but who are not interested in quitting smoking. So for those who qualify, we'll offer a 12-week supply of e-cigarettes, support to help switch. And then we also always provide compensation for study participation. And then the second study that we have starting will be extended varenicline. So among African-American smokers interested in quitting all nicotine, we'll provide 12 weeks of varenicline versus 26 weeks of varenicline. So 12 weeks would be the standard course, 26 weeks would be the extended treatment, and everyone will also get 8 quit smoking counseling sessions. And that's it. I don't know, do we want to do questions now, or should we go with, should I introduce LaWanda?
Well, thank you, Dr. Nolan. We can ask Hope if there are any questions for you, and then we can come back and after LaWanda finished and see if there's any additional questions.
Thank you, Ulysses. There is one question right now, and it's, were there any other outcome measures included in the analysis, such as nutrition or other lifestyle measures? And that is from Crystal.
No, Crystal, we have not looked at other outcome measures, just simply because our interventions are just targeting smoking as the primary outcome. So we'll look at other outcomes that are not just quitting, like days smoked, and other things like that, but we're not looking at other health behaviors.
Thank you. I was just, your comment about the SES, it was just as far as like those that are less disadvantaged or more advantaged, and that, I don't want to say correlation to the quit rate. That was very telling. So thank you so much. Appreciate it.
Yeah, thank you. Okay, so I'm gonna go ahead and introduce LaWanda. So LaWanda Swoops is one of our former study participants. She participated in the adaptive therapy trial, which I didn't mention today, but I'll let Wanda talk a little bit more about her experiences with that study. But just a little introduction of LaWanda. LaWanda is a mother of a 29-year-old son. She started smoking in college on and off for 30 years. She's been a non-smoker for almost a year, I believe. I think in June, it'll be a year, which is great. And she's been a homeless case manager for 36 years and has spent the last 4 years as a case manager at Swope Health Center. Wanda, do you want to go ahead and just talk a little bit about yourself and your experience in the Kick It at Swope program?
Absolutely. Thank you, Dr. Nolan. Thank you, Trisha, also for inviting me. So we meet again. We've done this before on the bench to, what did they call it? Bench to
Bedside.
Yes.
Bedside.
Which I
Yep.
enjoyed. So thanks for having me back. And yes, I wanted to remind you that this is my going on my year journey with being a non-smoker. So I'm a bit of a smoking snob right now with my with my friends that I've been trying to get to stop smoking. I must say that my participation in the Kick It at Swope program really basically turned my life around, because I really didn't think that I would be able to quit. And I would hear about it on the radio, and I said, well, let me give it a try. I said, because I'm going to start full time here at Swope, and I can't work at a healthcare center and be stepping outside having a cigarette. Not a good look. So needless to say, I really, really like the fact that they held me accountable with the, not just with the patches, but also with checking in with me once a week to see how it was going. I wasn't sure if these patches, because that's what I did the patches, and they actually worked for me. It was a little bit hard to keep them on because they didn't agree with my shea butter, but I made it work. I had to use about 2 or 3 of them a day, but when I realized that I was not feeling the urge to smoke, it really helped me out. There were some other factors. I wanted to, with my son getting older, I wanted to be a grandmother. I wanted to be healthy. I wanted to set an example, not only for my son and my family, but also for my friends. When you're a smoker, usually the majority of your friends smoke too. And so, just when I was on this journey, I wanted to bring people along because, I said, well, you guys want to get help? Yeah, Swoops, we'll do it. And so I said, you know what, y'all, I'm going to have to do this on my own. And so I did it. And then, they were really surprised that I quit, but, just being on the program and, somebody invited me after hearing it on the radio. And so just being able to feel healthier, not getting up with the urge to smoke, because that's really what it was. When I realized that I was probably going to have an issue, was when I was getting up, the first thing I was doing was having a cigarette. And then the last thing at night, having a cigarette. I didn't consider myself a heavy smoker. And that's so true, Dr. Nolan, because I would smoke maybe 5, maybe 4 or 5 cigarettes a day. So I consider myself a light smoker. So I didn't think I had a problem, so to speak, because I wasn't smoking all the time. But just see it as I got older, going up steps or, having to miss doing things that I need to do to be productive, to step outside and have a cigarette. So, I see a lot of people that I know that feel like because they don't actually smoke cigarettes, or because they smoke the Black and Milds, or because they smoke some other type of cigarette, that it's not as bad, or smoke something else that it's not as bad as smoking cigarettes. But I really must say that this has been a journey that I'm still on. I still do not feel the urge to smoke. So it's been a really, really good experience. And I hope to bring more people on now that I see that you're continuing with the program. So
There's a question in the box, which is, why did you choose the patch? I think you chose the patch because it was what we provided to you, but can you
Yes.
talk a little bit more? Sorry, I have dogs in the background. Can you talk a little bit more about, have you tried any other things in the past and how the patch worked in comparison to the other things that you've tried?
Sure. So I've tried to quit maybe, well, not gonna say quit. I say I paused because I didn't actually quit. I did try Chantix some years back. Did not like, I mean, it helped, but the side effects were not good for me. The really crazy dreams, it just wasn't good for me. So I didn't continue on with it. So I stopped or paused and started again. But the patch, I wasn't sure how it was going to work for me. That's the first time I'd ever used it, but that's what they offered me. And that was the first thing that they offered me. And they said, well, let me know if that doesn't work and we'll try something else. So the patch actually, it actually worked. You have to really want to do it. If you're not going to wear your patch, and if you're not going to check in, then the program's not going to work for you. But the patch is what they offered me, and so I really wanted to stick with it. I did have some in the beginning. I did have a little bit of irritation in the spots where the patch was, like. So I tried to put it, maybe on my back or someplace where it wouldn't fall off, but just some slight burning and irritation initially, but that went away.
Another question here. So how did you choose the duration of 8 to 12 weeks? Tell me how long, first of all, how long did you use the patch? Because I think you probably could have used it for up to 18. Did you use it for that long?
I kept using the patch until I realized that I didn't need it. And that may have been around the 8th or 9th week when I started to just decrease the patches, because I wouldn't leave them on all day. I would take one off and put one on. So I decreased my patch use until it got maybe to about 12 weeks. And then I didn't feel like I needed it at all.
Okay, and then that's great to know. I mean, so there's a standard length of time for all of these medications, and it's usually between 7 and 12 weeks. But like, for example, nicotine patch, gum, lozenge, those are all approved for long-term use. So individuals can use them for as long as they need, or they can taper themselves off when they feel like they don't need them any longer.
Yes, no, I did not need them anymore.
And Nikki, this is Hope. I'm not sure if Reverend Carter's question was also about your last study and changing the timeline. So I don't know, Reverend Carter, was that also about that? And he's on an iPhone, so he might not be able to respond.
Yeah.
I'm trying to make this thing work. Yes, that was why. That was she answered my question first. Thank you.
Okay, so the question is for the extended treatment study that will be starting, how did we decide on the time frame? So the answer to that is the standard recommended course of therapy of varenicline is 12 weeks. So we're going to do that, but then it has been used in other studies for as many as 26 weeks. And so there's really no contraindications for using it longer. And so we wanted to use it for the longest period of time possible. And we will then see if, if there's a difference between the standard course and the longer course of therapy. It could have an impact on how this medication is prescribed for smokers who are interested in quitting.
Looks like there, Hope, do we have additional questions in the chat?
There are no additional questions in the chat. I think, Ulysses, that we're small enough. Oops, there's just one that came through. How
Okay.
and it's from Lynn Miller. How can we get our friends and family in this program?
You know what? You can, on one of the slides that I presented, there was a phone number to call, and you simply just need to call that phone number. It's a voicemail, but that voicemail is checked daily, and we will call you back. I can also, if you reach out to me, I can provide you the information. You'll hear radio ads starting in the next 3 months. So you'll definitely hear more about these studies and see this phone number over and over and over again. But we would love program referrals. We would love
Nikki?
referrals. Yep.
Will you put the phone number into the chat for everyone, please?
Yes, I can do that. It may take me a minute, so keep going.
Okay, well, Hope, if there are no additional questions in the chat, we can move to Dr. Crystal Lumpkins and have her present her program. But before we leave here, I want to thank Ms. LaWanda Swoops for presenting, as well as Dr. Nola.
Thank you
So-
for having me. Thank you.
Thanks, Wanda.
All right, Dr. Lumpkins?
Yes, thank you so much. And also my just congratulations to you, Ms. Swoops, for coming upon a year anniversary. So, so great. And thank you, Dr. Nolan, for your important work that you're doing and continue to do with African Americans with this, this effort. So I will see if my screen, I can share my screen. Is that, does that work?
It did.
All right, that is good. Well, I'm Crystal Lumpkins, and I'm at obviously KU Medical Center, and lead with FaithWorks Connecting for a Healthy Community. And I am so happy that Ms. Evelyn Cooper and Dr. Miller, who are also members of this consortium, are with me tonight. And so what we are going to present, if this slide will move. Okay, there we go. So tonight, what we are going to share is essentially a story. Many of you know that my background, I am a former news reporter, so journalist. So some of this is being woven into our presentation today as a narrative of who we are, what we've done, and what we've done over a number of years, because the approach that I have taken as a communication scientist is community-based participatory research. And so in the research that we do, it is long-term and occurs over a course of several years, and just integrated. So just want to share with you some of the things and the highlight of what we've done to address cancer health disparities. What I will say as we get started, I wanted to formally introduce my colleagues in the consortium. Mrs. Evelyn Cooper is a registered nurse and is very active in a local church, Palestine Missionary Baptist Church, which I think is one of the largest churches on the Kansas City, Missouri side in Jackson County. And she joined the Department of Family Medicine and Community Health as a part-time temporary research associate in 2020. And she's also the chair of our cancer-related genetic counseling and testing community advisory board. Dr. Lynn Miller is also here tonight to co-present. And she's one of the inaugural members of the consortium and has been a long-time community advocate She's also a published author in her own right, but is also a published author on our research that's the cancer-related genetic counseling and testing, and is also a member of this, the CAB that Evelyn leads. And so just a little bit about the consortium. It is one that is a collective of collaborations, research initiatives. For many of you are familiar with this, but for those that are not, this just gives a little bit more about the consortium. And what we're trying to do is to continue to sustain a strong network of primarily faith-based organizations in the bi-state area, and also possibly expanding from that, the bi-state area here soon. And then also through these partnerships, we have been able to, I would say that Evelyn and Lynn will chime in here too, to reach goals to have some sustainable health promotion programs. So the idea for us, as community-based participatory researchers, are that we're helping as a collective coming together, but we're wanting to also see that after we have worked together, that churches, faith-based organizations are leading the efforts on their own, and then we're being asked possibly to come and help in other efforts they have as far as health and wellness. I thought we thought it would be good to just look at a snapshot as this forum is called the Health and Freedom, just what it is as far as historically that really has driven, unfortunately, some of the health disparities and health inequities. And so this is just a timeline. I know that many of us are very well aware of several events on this timeline that spans from, over centuries. But I think it just serves as a reminder of what we're up against. And I'm glad that we're having this conversation tonight, because not only is it, important to look at the issues, the disparities, like we saw the smoking, just the importance of smoking cessation among African Americans, but looking at a broader picture and those health disparities of some of these issues that have exacerbated health outcome. Just here's a visual of the cancer disparities. And so you can see that in this, I think it's on your left as well, or maybe it's on your right, as far as just the areas of the country where you see in the darker color where those cancer cases are occurring. In Missouri and Kansas, they're in the darker colors. And then on the other side, you see a number of cancer cases and deaths where you look at the Black males, very disproportionate. Oh, it's trying to get ahead of me. Maybe it's trying to help me to stay on time there. But this is just again, and you can see a side-by-side comparison of male and female, and then also those statistics, those numbers, which we're working very hard to address. And so how can we address that? We've been working again with people that I call boots on the ground, and those individuals that are in those spaces and places. And so here's just a quick timeline of things that we have been involved in and that are related to funding, where we, like Pastor Carter's on this Zoom, and Pastor Groves is here, and some of other individuals that have been very important in this effort, going through leadership training from Kansas Leadership Center and having a shared governance and language, having specific efforts with PCORI, which is this Patient Centered Outcome Research Institute, to help us to engage. And through that process that I follow, or we follow, is having all of those voices at the table to inform the research. And so I'll stop here and give the floor to Dr. Lynn Miller, who has been very involved, has been also with me co-presented on one of the bench to bedside talks. So I will stop and let her talk about her experiences with our consortium.
Good evening, and thank you so much for allowing me to be part of this beautiful program and presentation. Our history with Faith Works Connecting for a Healthy Community began when I first met Dr. Lumpkin at a Baptist Ministers Union meeting back in 2010. And she was presenting information about research to assist African Americans with increasing awareness about colorectal cancer detection and prevention. And I was there to inform them about camping opportunities for urban youth, because I was the director of ministries and I worked directly with the youth department. And immediately, once she started talking, I recognized the value of the Black church becoming one of the major venues where African Americans can feel safe about getting involved and bridging the gaps and health disparities in the Black community. Also where African American churches can help establish healthy living goals for Black youth, and also developing healthy conversations within Black families to dispel fears, to create better communication between Black patients and their doctors. And last but not least, getting Black people involved in medical research. And so my background, as Dr. Lumpkin has said, my background is I was a director of ministries at one of the local churches in Missouri and Kansas City, and I was there for 40 years. I just retired in 2019. And also my background is I'm the daughter of a registered nurse. And my mom was one of those kinds of medical professionals who would go around and assist families and friends and church members and help them with any kind of medical question or medical need they had. And because I would be with her, or we would, that they would be members of the church that we both attend, it made me become informed about health issues and what bridging the gap looks like for African Americans. And it introduced me to problems that African Americans face, specifically with cancer-related sickness. And it also, I learned what a hard blow that cancer was doing to our church family and church members. You just kept hearing about it all the time. And so when I partnered with Dr. Lumpkin, it was one of the best decisions I've ever made in genuinely making a difference in the Black community. It was one of the most important partnerships that I had made during my 40 years working at the church. And the other top three are also partnerships that I made working with health community initiatives. But this partnership was one that I knew would help the church become an entity that would help with medical research and study. And so since meeting and getting to know and working with Crystal, I have learned a lot about medicine. I'm what you call, I'm a medically illiterate person. And I don't know if you know anything about people like that, but because my mom was a nurse, I didn't have to know anything about medicine. She'd just tell me. And but working with Crystal helped me to understand the disparities. It also helped me understand the results of systemic racism that we're experiencing in America, and how they have had a long-term effect on how on the Black community specifically, and how it has affected how we live. And then the most important thing is how it has affected the next generation, which were the people that I specifically minister to, and I knew they needed to know more about, the disparities in our community. And so in conclusion, one of the things that really struck with me in working with Dr. Lumpkin was that your health is your wealth. But African Americans are still experiencing this great health and wealth gap, and why, and the reason why is because African Americans are still having the burden of high cancer rates, facing greater obstacles to cancer prevention, cancer detection, cancer treatment, and cancer survivals. And many of you already know how high those statistics are, but we're the sickest, we die more, we have the highest death rate, we have the higher incident as a people. Black men have double the rate of prostate cancer. Black women are 40% more likely to die of breast cancer. African American women experience a high discrimination rate with the health provider visits. And then just the fact that it's the Black community, people who live in predominantly Black communities are also getting diagnosed with cancer after it has spread, along with higher death rates and lower rates of survival and so forth and so on. And so one of the things that came to my mind about your health is your wealth is that if African Americans are spending more money on medical bills, then our health is taken away from our wealth. And if African Americans have to be unable to go to work and not be productive on their job, it's taken away from their health and their wealth. African Americans are having to feel less confident. That's taken away from their health and their wealth. Insurance, that's a whole nother, elephant in the room. Exercise. And then just the fact that when you are healthy, you have the ability to think better. You have that better cognitive ability, your wizard brain and your lizard brain, all of that stuff. And then the last and most important thing is about health is an investment. And so if we're spending all our time trying to be healthy, then we don't have any time to spend in order to take advantage of any health benefits, because we're always chasing, the health thing. So if we, as African Americans, don't take time to learn, to talk to each other about our health, both emotional, psychological, social, physical, and economical, we are just doomed to just have even be at an even bigger disadvantage in obtaining wealth and health for our future African American children. So that's what got me going, and that's what keeps me going. And I could say more, but I'm going to turn it over back to Crystal.
Well, thank you so much, Lynn. I really appreciate just you sharing your experiences, and also just as I would say, like a clarion call for us to continue this work because of the persistent, just issues that we face as African Americans. And what you were saying really hits at the social determinants too of health. And how is it that we can leverage, what it is, our, just the collective, and have solutions. And you being in that position as an advocate for more than 40 years has been instrumental. I've just heard, again, several stories about what you've done to change infrastructure and to use, as we talk about trust and building trust, and how that actually is economy and money in the bank. So just wanted to say that. So in the interest of time, I'm going to share my screen again, and Please let me know if is this a double, is it the display okay, or is it double here? Probably.
It does have your notes on it also.
Okay, so I'm going to, hopefully that works there.
It did.
Thank you. Thank you so much. And so what I'll do is just quickly talk about some highlights from the research projects that we have had. And again, this is a continuation of research that has started, even though the first was our colorectal cancer project that was, I alluded to earlier in our timeline of activities. It very much so is complementary with others. So we'll talk about that just really briefly, a COVID-19 project and the cancer-related genetic counseling and testing. And Ms. Evelyn Cooper will also assist me with that. And what you'll see, I'll just note there's some pictures here, presentation. I also purposefully put this other picture about the protest. This was a protest, a collective during the time of COVID-19, where we really said, you know, we have to respond. It's one thing to, we're collecting research, but we also have to be responsive to what's going on around us in the world today. So just really quickly, again, the communicating CRC is colorectal cancer, abbreviating that for prevention. This was our second NCI funded project that we were looking at how churches were positioned as social marketing, which is essentially borrowing from commercial marketing, looking at colorectal cancer screening as a commodity, a product, and seeing how churches were positioned to communicate, socially market this type of screening to churches. And so we had 8 churches involved. And so we had comparison in also the churches that, as we say in, our intervention churches, there was a campaign in those churches. And so these churches, individuals, Palestine was one of them, where we trained individuals that were in those, like nurses, medical professionals in that church, to deliver and market this information to their congregants. And in the comparison churches, myself, other KUMC individuals communicated a CDC campaign. And so there really was no difference. There was not a significant difference between that because of some lessons learned, because I essentially was a part of that other, it was almost an intervention in itself. But what was very significant, that we had a very high rate of behavior. The behavior outcome was a completion of a fecal immunochemical test, a test to detect colorectal cancer. And so we know that that's like a first start or secondary screening. And after that would be a colonoscopy, which is the gold standard. And there were 2 positive tests. And so I'm blanking on the Palestine, Evelyn, Ms. Johnson was actually served as a testimonial for us in this journey. So those were lessons learned there. And this is just a picture where we were at KU Lawrence. There were several pastors that were there. I think Pastor Groves, there you are in the back, were there part of the taping when we did the public service announcement, which was a part of this campaign, and that's one of 3 publications from that study. So the COVID-19 health communication study was one in which we were wanting to be responsive. We talked to pastors, we interviewed them. Another colleague and myself from the School of Journalism, actually through this process, we gained, talked to, other leaders that were not involved in the actual in-depth interviews, and asked them about what do they think about the questions that we were asking. And so we asked them about their perceptions, their opinions, their knowledge about COVID-19, and how do they see themselves as communicators of this. And so here's just that number is actually much higher than that. It says 11, but there was 21 pastors. And so here's just some of the findings from that. as far as recommendation about messaging, and recommendations about content. There should be messages of hope in this population, testimonials, incorporating simple, easy to understand language. And so some of the other things too that came out of this study was we had a health communication workshop. And when we sent out surveys, this was something that I think at that time gave them pause to think, okay, well, my technology, maybe there's some things that I can do different now that I'm in this, that we're not meeting in person anymore. And so we also presented at the Missionary Baptist State Convention of Kansas last April. And this gave the pastors a way to for communication assessment. And finally, we recently had a COVID and Cancer Forum March 22nd, which many of us know March is Colorectal Cancer Awareness Month. So let me pause and ask Ms. Cooper, did you have anything that you wanted to add? Oh, you are muted.
No, not at this time.
Okay, I just want to make sure. So we'll move on into, this is where I will ask for Ms. Cooper to chime in here because she has been so just resourceful and really driving force behind this CAB for the cancer-related genetic counseling and testing communication asset mapping that we process, community asset mapping here. And this is just a bi-state where we actually have participants that were a part of a workshop in October of last year. And so here's just a brief overview about this project where community asset mapping is essentially a strength-based approach to looking at how to develop community development. And so we were borrowing from this community asset mapping process to start a process to look at developing a communication asset map as it relates to a tool for church health liaisons, a communication asset map that would help with looking at those areas within a specific geographical area. And we chose 2 churches where these church health advisors could have a map that would help them bolster their health promotion about cancer-related genetic counseling and testing. And one thing I'm skipping over, I know because of time, is that we've had other projects complementary to this cancer-related genetic counseling and testing project. So I just want to make sure I say that. And some of those, that was pre-COVID with the picture that you see there. And that was one of the meetings we had back in before like early 2020 or 2019, where we were hearing from churches about what their thoughts as far as those semi-structured interview guides, or here that meeting was at Glory Bible Fellowship, and getting information from them as far as their thoughts should go into the design of some of the formative work we've done. So I just wanted to say that. So now I want to get to the creation of that CAB. And so that's where I would love for Evelyn to chime in here as far as how we were able to create this CAB very specifically for this project.
Thank you all for the opportunity to share this project with you. As Crystal has said, FaithWorks is an advocacy for health communication projects, and specifically cancer-related genetic testing and counseling. This CAB was specifically interested in the disparities, of course, and the barriers that African Americans have with communication, whether it's communication with their families, asking their parents, grandparents specifically what one of their relatives died of, rather than just say that, she died of heart disease. Well, did she really, or was there something more relatable? So it's so important for specifically families, Black families, to be open to discussing cancer and genetic counseling specifically, because there's an opportunity for us to take advantage of that. The CAB specifically consisted of healthcare professionals. We had a nurse, we had an occupational therapist, physical therapist, we had a cancer ambassador, we had a pastor on the CAB, we had a pre-survivor, co-survivor, we had researchers, and we had the CAB help us come up with assets in the African-American community that we could put on a map that African-Americans could have more accessible to information, to not a lot of myths, not a lot of health jargon or health language that wasn't familiar with them. We wanted a CAB to help us develop realistic ways to collaborate with other community organizations, faith-based churches, churches talking to their congregations, opportunities for true relationships, opportunities for communities, this CAB, to train the trainer, so to speak, so that we would reach out and talk with healthcare professionals, to researchers, and develop a communication tool piece for us to take back to the community. And then we looked at assets within the community to put on the map, and not just place brochures here and a brochure there, but to look at realistic places that African Americans visited, to partner with that particular asset, whether it's a barbershop, whether it's a church, whether it's a health club, to partner with that particular asset facility, so that they also would encourage and engage and promote communication tools that are to be developed, that are usable tools, that we open up a real health communication conversation with people, and not have things like cancer be words we don't want to talk about, we don't want to share, we're embarrassed about. We also wanted to have a CAB that would empower African Americans to speak up to their physician, to communicate, give them information that they need to know to take back to their physicians. Then the CAB developed the participants for our workshop, and they selected individuals similar to what we had on the CAB: ministers, cancer survivors, educators, pastors, ministers, mission leaders in the group, churches that routinely have support groups, so that we, again, begin to develop communication processes that are realistic, that are usable, and we can begin to educate our African Americans regarding health-related issues. That pretty much the nuts and bolts of it.
Thank you so much, Evelyn. I really appreciate you going through that, because I will say it was a long process. We learned a lot from each other. I think we had probably about 8 meetings, CAB meetings over the course of 8 months, and learned together how is it that, with this, many people have not heard of this, cancer-related genetic counseling and testing, and why do it? One of the things that in formative research, we had focus groups with churches, faith-based organizations, and also a broader African-American sample. Why do it? I don't want to know, or I want to know. And we saw a lot of differences between younger demographics, older demographics. And so thank you so much. And the genetic counselors, I want to say, that weren't able to make it tonight were amazing. And it still work with them, Rod Phelps and Katie Nelson. Want to make sure that I said that, because they really made such a difference in being there and a part of the CAB, and Katie Nelson particularly, and educating us along the way. Want to just go ahead and just share some of the preliminary results from our workshop. So the CAB was very instrumental in recruiting these individuals. I call them community scientists. They went through a community IRB training, all of that. And so we had an average age of 61, predominantly female or majority female, non-Hispanic Black. Most had coverage, and this was a highly educated sample. And so it will be interesting when we have, do more work in reaching out to more community members. And the income ranges, these were the, as far as the larger part of the sample. And then we had a great representation from zip codes, and then also counties. In our breakout groups, we had 5 breakout groups represented from Kansas and Missouri. And as Evelyn already talked about, the different people that were part of the CAB. So we had a great mix, predominantly female, but had a great mix of people that were leading and then co-leading or scribes for those breakout rooms. And we had, and then there's just a racial ethnic background. And we had some of the themes that came out of these breakout or these groups that when we talked about, Evelyn was talking about that process for identifying those assets. We, looked at the boundaries were around Bethel Church on the Kansas City, Kansas side. And then on the Missouri side, it was Palestine. And so we were very intentional. There was purposive, I should say, sampling, in which we were looking at the 5 to 10 mile radius around those churches to see what are those spaces and places and spaces. Somebody said a nightclub, and we were like, oh, really? So just saying. And so we were looking at, some of those things that came up. And then also just trusted people that would be within those spaces, barbershop, the laundromat, the library. People were being very creative. So we started with the CAB first, and then we had a set list when we had those community members to go through that process. And so because of the facilitators, there were differences, not major differences between the conversations. And then because we had a mixture of Missouri and Kansas people within those groups, sometimes some individuals were not familiar with, the areas in which we had defined. And so there were some challenges also with Zoom technology because we were adopting an in-person process. So, and I don't know if, there's any other comments that you wanted to make. Either Lynn, you were one of the great facilitators. I think Angela Williams is on here. You all rank yourself as number 1, team 1. But I don't know if there's any other comments you want to make. I do want to say that I think Dr. Godwin is on here as well. What we have really appreciated too, that when we had this forum or this opportunities, we also wanted to make sure that, we're telling you about testing, but what else is there? And so we were able to partner with Casey Care Clinic for them to be able to have some type of, the testing as well. So, but I don't know if either one of you wanted to have a comment. I know we're probably running out of time.
Go ahead, Ann.
I just want to say it was a great experience for me working with all of the different people. We also had a doctor that was part of our CAB.
Thank you, Dr. Margaret Smith.
Dr. Margaret Smith.
Yes,
And so
yes.
our CAB had a broad selection of individuals who had, medical experience and who had experience with cancer as patients or caregivers, and family members themselves. And it was really a great experience.
Thank you so much. And I think there's a question I saw in the chat, the next step. So yes, the next steps are that we want to actually create the prototype for this this tool that we were alluding to earlier. So that is definitely, this was a pilot, and that is the intention for the next step. I hope that answers your question. I think we just had, maybe there was just one more. Does that answer the question? Is there another question in the chat? Oh, thank you so much. So I just wanted to share, just a statement that we really, this is, dear and dear to us, just the collaboration that we have, and that, we're hoping to continue, this work in health communication, promotion, community engagement, advocacy, all of that. As we see that it is so important, we see it as overlapping, and it's a part of who we are and what we do. I'm not trying to be corny, but in the space of cancer genetics, we're thinking it's woven into our DNA, right? And so we're hoping to continue to add to the body of knowledge and scholarship in cancer communication, and being a force to raise consciousness and knowledge about, these cancer disparities, and continue to address, the social injustices that we're seeing. And so as my, just growing up, I remember my parents saying, if you're not a part of the, solution, then you're part of the problem. So I definitely want to be a part of the solution. And so that, saying that, we just have some, where our website, also Facebook, and then that's the KC Care. And I will then stop sharing. And that we'll stop right there. So if there's any other questions for any of us, not just me. But.
I believe you're on mute, Mr. Wright.
So thank you, Dr. Lumpkins, for presenting, and thank your team, Dr. Miller and Ms. Cooper. We appreciate you sharing with us tonight. So Hope, did we have any additional questions or final questions that come through?
We do not, but if there's anybody attending that wants to come off mute and just ask the question, we would, I think, have about 10 minutes that we could respond to any additional questions or get out early.
I had a question, Hope. You mentioned genetics testing, so I'm familiar with BRCA testing. What other genetics testing did you guys do or inquire about in these groups?
Well, we had Dr. Rod Philp and Katie Nelson, who are genetic counselors, first of all. And so based on self-report, if an individual said that, they had a family history, and in another study that I referred to, we had an opportunity for individuals to do a pedigree. And so based on that pedigree, they were able to assess and see if the person was eligible for testing. And a part of that was also providing the opportunity to test, which we had funding, pedigree, yes. And so pedigree is essentially a family history. Essentially, depending on like first degree relative had cancer, then that could mean that you are a carrier. And so that is what we were able to do. And depending on that, that was when the testing would occur. So, and I failed to mention that, just really thankful for the funding, like I hope I put that up there, the Sean D. Memorial Foundation was was really responsible for helping us to do some earlier work. Does that answer your question?
Sort of. I just was interested in knowing like what other types of genetic testing you guys did. So if it was for BRCA or if it was for diabetes or hypertension or things like that. If you could kind of share what those tests were, like, you know what I mean?
Yes. So I know the testing that we had or the counseling was cancer related. And so it is probably the BRCA, but I am not an expert in that area. I just will be, just upfront about that. But I can definitely, recommend or actually get information for you to get more information about the different types of the testing.
Crystal, can I
Yes,
chime
please,
in?
Dr. Godwin, please. Yes.
Yeah. So to address that question, yes, what we end up doing is identifying people that have a significant family history, and then we will refer them to genetic testing. In this case, it's a cancer-related testing, as Crystal mentioned, but it's a panel of genes. And so as the field has continued to grow, we can continually identify new genes that, if you carry a mutation, those genes increase your risk of developing cancer over your lifetime. And so what we do is we send out and do a panel testing, and those will have many genes, most of the cancer-related genes that we know of now that could predispose or increase your risk of developing cancer. So BRCA1 and BRCA2 are part of that screening, but there are many, many more genes. And so but mainly what our screening ends up doing is we're identifying those individuals who have an increased risk for potential breast or ovarian cancer and colorectal cancer. So all the kind of testing we do will cover most of the genes that are involved in leading to increased risk there.
Okay, thank you. Yes, that's kind of what I wanted to know. Absolutely. Thank you.
Thank you so much for answering that, Dr. Godwin. I really appreciate. Did someone else have a comment? Dr.
Can I
Miller?
ask the question? Sorry. This is Angela. I wanted to ask the question to Dr. Godwin, if it's okay. When you were talking about the different type of testing for genetics, I know when I tested positive for BRCA1, I was given a percentage, which was pretty high, which it put me in a position to have to make the decision to go ahead and do a bilateral mastectomy. My question is there a certain percentage where you could determine whether or not if it's necessary? So for example, if it was only a 50% or 40%, would an oncologist then advise you to go ahead and move forward with that? Or would they say, okay, if it's over 80 or if it's at a certain percentage, you should move forward? What percentage would they recommend whether or not you should move forward with doing something? Does that make sense?
Absolutely, and that's something I've been working on probably for 25 years. And so, no, we seriously, we're currently, I'm in a consortium, a group that is throughout the entire globe that's studying risk associated with carrying a mutation in BRCA1 or 2. Number one, all BRCA1 or 2 mutations are not created equally. Some give you a higher risk, some have a lower risk. There are other genetic factors that can also influence whether you're 85% chance of developing breast cancer or less than 50. And so a lot of the work we do is continually trying to refine those risks so that people have a better choice. to when they want to have a prophylactic oophorectomy, meaning remove the ovaries and fallopian tube, or if they're having a prophylactic mastectomy, removing the breast tissue that's at risk. So the fact that we can give you an absolute risk or closer to absolute risk, saying that you're 85% likely, 50% likely, or 40% likely, it still comes back to the patient and the individual and what what they will tolerate based on their risk. And what we're finding still in the areas is as people age, which again is a risk factor for cancer, but as people age and they're past their reproductive years, they tend to look stronger at having the prophylactic surgeries, especially in the case of ovarian cancer, because we don't have a very good screening tool to identify ovarian cancer early. And that's really one of the issues. That's something I work on in my research program. With breast, it's a little bit different given the fact that mammography is very effective if women participate routinely, and normally people who are at increased risk will participate and be more diligent about getting their screening done. But it really comes down to being a choice, and you will get a variety of different suggestions based on your oncologist, based on your surgeon, what they might recommend. And I've been dealing with a case just recently where I recommended a second opinion for this person because their oncologist suggested to have both the breasts and their ovaries removed, yet the risk factors weren't quite as high as somebody who's carrying a deleterious BRCA1 mutation. And so a lot of it has to come down to what the patient is willing to put up with their risk, because you'll get a variety of different kinds of opinions by your oncologist, by your genetic counselor, by your surgeon. But in general, what I find is that we see a very good reduction in the case of ovarian cancer and breast cancer if you have prophylactic surgeries later in life when you're willing to undergo surgery, undergo in some cases it induces menopause earlier by having your ovaries removed. So there's lots of factors that go into it, and a lot of times it has to come down to what the patient is willing to risk. And whether you have a 50% chance, whether you have an 85% chance, it is still a gamble. And so the patient has to ultimately make those decisions, but you'll get a variety of recommendations still from professionals in the field. But I'm coming from the areas where I've involved for many years, and those individuals who are past the reproductive years very strongly would suggest that they have deleterious, again, cancer causing mutations in BRCA1 or 2 to seriously look at removing the ovaries, and then maybe doing more monitoring in the breast. But some people do both at the same time. So there's not a clear answer, as you can understand. It's actually what the patient is willing to risk.
Right. Thank you.
Okay, we're coming to the end of our time slot here, but I wanted to thank everyone for the questions and thank Dr. Godwin for those excellent answers and commentary that he gave. So Hope, thank you for posing the questions from the participants tonight, and just wanted to check with you to see if there are any final questions here.
There are no more questions, but I really want to thank you, Ulysses, both for your partnership with the KU Cancer Center Community Advisory Board, and we so very much appreciate that, as well as tonight. And I want to thank both all the presenters as well as the community that has joined us to really engage in this great conversation. We would love to continue a conversation like this and periodically have this opportunity. So if there's something that something of interest that you all would like to hear, or a presenter you would like to have us asked to join us, we would be happy to do that. So thank you, Ulysses, Crystal, Dr. Miller, Evelyn, and I think we lost Lawanda and Nikki earlier. They had other commitments, but thanks everyone.
So along with Hope, I want to thank all our presenters tonight for sharing their time and expertise with us. I will also want to extend a special thank you to all of the participants for joining us tonight. We appreciate you being here with us, and we want you to stay safe and healthy, and we want you to have a great evening, the rest of your evening. So thank you so very much for joining us. All right, good night, everyone.
Right.